now have drugs that are available. We've got these complement inhibitors or factor B inhibitor and a C3CB inhibitor. And these drugs are approved and patients can take them, but there are some real practical issues with implementing them. So, Suneel, you were talking.
Well, just in community practice. I mean, we're an isolated, clinic, not affiliated with a major medical center, hospital. And so, the key requirement of vaccination for encapsulated bacteria, meningococcal vaccination, pneumococcal vaccination, Haemophilus, et cetera. And
it's those three.
Those three.
It's strep, it's H flu, and it's Neisseria.
And this is, again, not in the routine practice of nephrologists at all.
No way.
At all. And so to then logistically navigate patients, where do I get vaccinated? Do I need an order? And I recently had a patient say, the pharmacist told me that their Men-B vaccination is only approved for up to age 20. And it's not approved for, but clearly this is not for a
special circumstance. Right. They're not going to college.
Right,
they're not military.
So these are all things that are completely out of the norm of nephrology.
And we don't know how to answer these questions.
And so we have to, to not have this protocol set up at the same time. Thankfully we were part of some of these clinical trials. So we had a process to go through this. Gotcha. But otherwise, if you haven't, then you're like, how do you do that? So I think that's one of the logistical challenges that will ultimately inhibit its use.
I think it's very important because for sure you have to vaccinate these patients. Also, I haven't read the label, but at least for the other is mandate the FDA has vaccinated.
You have to be vaccinated.
And
I think it's also one of the reasons that the drug was so safe in the trial. Right? I'm sure all these people were vaccinated. They're like, okay, there's no encapsulated organisms. And vaccines work.
But you also remember that it takes 6 months to be fully vaccinated against meningococcal meningitis, all right? So, but then say, well, we're going to go. That doesn't mean that you cannot use the drug. So what I do, I give them the first dose, and if a patient is progressive, then they get penicillin twice a day until they get the second dose of the vaccine as prophylaxis. So that is so it's not that we cannot use.
That just makes it more complicated. I mean, it works, but it's just to your point, it's even more complicated if we're going to time it and also give penicillin while we're waiting for it to kick in.
Penicillin.
Remember that?
No, I don't. I'm not sure if I've ever prescribed it.
Twice a day. Yes. Yeah. But what I mean, it's important to people know that it's not. I mean, this is important because it's not something. Oh, I have a patient that's progressive disease. I just gave vaccine. I'm going to wait 6 months. No, you don't need to wait 6 months.
Yeah.
Again, goes to individualized medicine.
But this is not individualized. This is blanket coverage, right? If you're going to be given a complement inhibitor, you need to be guarding against these issues. Yeah.
The REMS that's just a one-time thing. There's no follow-up for the patient. It's a one-time thing for the prescriber.
Yeah.
Important. That's different than the REMS for.
This is not lab monitoring.
No,
this is different, but it's the same. But it's the same issue. Right? It's the same issue. This is a critical patient safety issue with these medications, and I think Suneel's point is correct. This is outside of our standard practice. We just don't know the answers to the questions that patients are going to ask us.
But when I said of individualized medicine, is this side is the patient can time to wait, and you can decide to the patient the patient normal kidney function has 3 grams of proteinuria, but the clearance is 110 mL per minute. You can say, look, we can start now. Your kidney function is beautiful, normal. We can wait 6 months, or if you really are, then we can start you now and give you a penicillin V. Then it's a discussion that you have to have to the patient.
Yeah. So the other thing I think is that just the elephant in the room for me dealing with young adults is the fact that they have to inject themselves twice a week.
With pegcetacopine, yeah.
Yeah, I mean, that's right. For how, I mean, we don't know. Does it forever?
Forever?
Likely.
Maybe.
Yeah.
Let's go back to the
That's
investigative cause, because if it's a complement,
that's right. It's going to keep
that's good.
Right.
But if it's a genetic mutation, I mean, then it's likely that it's
right.
Life.
Yeah, that's a lot.
I think that there's multiple things about that. One is I think this is where it's good to have options, right? I have had patients though who actually, not necessarily with this disease state, but for other disease states, prefer an injectable because then they don't have to remember to take a pill every day.
Right.
And I think the point is that it's good to have individualized options, and it's good to have data for more than one therapy, so that really we can say, okay, what works best for you? Accessibility, tolerability. I think those are going to be the two things that ultimately dictate how we use these.
Yeah, I think it also depends the age group. This is a tough age group.
Yeah, no, I think
You know, I mean,
Is it a large volume?
I'm sorry.
Injected? Is it a large volume?
I mean, it comes in like a pen thing. So
it's
it's an auto, yeah.
It's like it's an subcutaneous infuser.
yeah.
Yeah,
Have
they,
you remembered
they
that
put it
the
on your
guys-
body for like 30 minutes, and it slowly infuses it during those 30 minutes. And you can kind of go about your day while it does that infusion.
Oh, that's very different than I would have thought.
Yeah, it's
Now remember
I
that
realize that.
it's not Ozempic.
lupus guys like to use some drugs that are inject subcutaneous, right? Also weekly or monthly, whatever. So, yeah, it's a little problem, but I don't think that that is the main issue. But of course, yeah, it's
yeah,
not
but
that
in the-
it's
in
not
that-
ideal.
I mean,
Yeah, and that age, that age group is like, the diabetics stopped taking their insulin because they don't want to deal with it, right? So I think it depends on who you're talking about.
Do you want actually? I think it's important to highlight. Like you treat a very distinct age
Yes.
population. I think that.
Right.
I think that's different
Very-
from our experience.
Yes, and that's the key time for non-adherence, right? That
So it's like 10 to 8, 12 to 18, or what's the?
oh no, it's 18 to 24
18,
or so, and that's 17 to 24, but that's the time of highest non-adherence, most complications of your underlying disease, most hospitalizations across all chronic illnesses in that age group, right? Kidney grafts, kidney out, transplants are lost more commonly in that age group than any other age group at any time, and no matter when you've gotten your kidney. So you could have gotten your kidney at 10, but you're more likely to lose it at that time
It's
period.
purely a compliance.
Just purely do you remember what it was like to be 18?
Yeah, wow,
I
you
don't know.
I was perfect.